Okay, good morning, everyone. I want to welcome everyone here and everyone on C-SPAN to the American Enterprise Institute, where we are having a discussion today about the Medicare Trustees report. The Medicare Trustees report was issued late yesterday afternoon and is an annual report that gives some indication of not only the current fiscal status of the Medicare program, but also the long-term outlook. My name is Joe Antos. I'm the Wilson H. Taylor Scholar in Healthcare and Retirement Policy at AEI, and I will be introducing the panel in just a second. But I did want to highlight a few things that the trustees said in their report. Perhaps their biggest concern has to do with the outlook, as they said in their summary. A major concern has to do with the growth of healthcare innovation, which has its positives and negatives. The positive, of course, is that with modern technology and modern techniques, we're able to cure or at least address the serious health conditions of many more people than we could have in the past. But as the trustees say, while most healthcare technological advances to date have tended to increase expenditures, the healthcare landscape is shifting. No one knows whether future developments will, on balance, increase or decrease costs. Well, that could be, but one might take a more realistic view of that, in my opinion. Let me also cite a critical point that the trustees made in their report having to do with productivity. The Patient Protection and Affordable Care Act, or the ACA, has a provision in it that the current administration is not taking any actions to remove, which sets payment reductions according to the growth in general productivity and payment reductions to healthcare providers. And as the trustees say, healthcare providers will have to realize productivity improvements at a faster rate than experienced historically for this policy to avoid leading to serious erosion in access to care and quality of care. These are very serious issues. And then finally, let me cite I like to think of them as the public trustees in exile. The former public trustees, Bob Reischauer and Chuck Blahaus, and they wrote a paper before they saw the report yesterday, but they made a very important point, which is that delaying action on Medicare's fiscal challenges until a crisis is imminent, which too often has been Congress's approach, would not only have adverse impacts on beneficiaries, it would severely restrict the remedies available to address the problem. Waiting to act could have devastating consequences. So with those upbeat words, let me introduce the panel. Our first speaker will be the Chief Actuary for the Medicare and Medicaid programs, Paul Spitalnik, to my right. And then the panel, after Paul gives his talk, the panel will make some comments and we'll have some general discussion and we'll open it up to the audience. The next speaker is Maya McGinnis, who is president of the Committee for a Responsible Federal Budget. Then there's Gene Sterling, who is an Institute Fellow and Richard B. Fisher Chair at the Urban Institute. Then we have Bob Moffett, a Senior Fellow at Heritage Foundation's Center for Health Policy Studies. And then finally, Keith Fontenot, who is a Managing Director at Hooper, Lundy, and Bookman, but has long experience at the Office of Management and Budget, CBO, and other related organizations. And so with that, Paul, please give your presentation.
All right, good morning. Thank you, Joe. I always appreciate the opportunity to come to the American Enterprise Institute and talk about the financial status of Medicare after we release the annual trustees reports. Not in the interest of burying the lead, but this year's report is not very different than what we've seen in prior year's reports. But that in and of itself is actually a pretty big story. That we have a very different, the current members of the Board of Trustees have a very different perspective on healthcare than the prior administration. The members of the Board of Trustees are, there's 3 cabinet officials, the Secretary of Health and Human Services, the Secretary of Treasury, the Secretary of Labor, the Commissioner of Social Security, and there's also typically 2 public trustees. Those public trustees do play a very important role, and that position has been vacant over the last couple of years as well. But the fact remains that in a shifting administration with very different perspectives towards healthcare, as evidenced from the debate on the current health reform efforts, the fact that the underlying approach, the assumptions, the methods, and ultimately the results of what we're going to see as I walk through the key findings from the report are not very different. And I think that really is a testament to both the current and the prior administration for the role that the Board of Trustees play in overseeing these very important programs. And that they are free of political perspective or bent, that they are truly an independent, objective evaluation of the status of these trust funds. And that in and of itself is actually a pretty important observation and reality. So with that, I'll actually turn to my presentation. I'll walk through, the agenda is going to walk through the current status and evolution of the program, walk through the formal evaluation of the financial status of the programs, which is the key objective of the trustee report. The Independent Payment and Advisory Board, or IPAB, is something that that could have garnered a fair amount of attention this year. Again, to not bury the lead, it was not triggered this year, so it's therefore not getting a significant amount of attention. What has gotten a fair amount of attention over the past several years has been the Part B premium rate. So I'll talk a little bit about the evolution of where we are today and what the 2018 Part B premium. And I'll summarize, for those that have seen my presentation before, I apologize. It's fairly similar to what it's been in years past, but I have added what hopefully will continue to illuminate how these programs are evolving and changing over time, and hopefully in a way that you can actually visualize that these are big programs that move relatively slowly. But even when they move relatively slowly, there can be some pretty substantial changes over a relatively short period of time. I like to start my presentations always by putting up these comparisons. And this is a comparison of the split between how the program has evolved, basically how spending by Medicare has changed over time. Each and every year, the Board of Trustees are put out the report that have a 75-year projection. And so what we are trying to do is forecast what this program will look like, what the spending will be 75 years from now. And if we were to jump back to just 1976, or just move back 40 years, and look at what the program looked like at that point, where this was predominantly an inpatient hospital program, nearly 75%, more than 2/3 of the spending was for inpatient hospital in 1976, as compared to what it looks like today. And there's a lot more pieces to that pie, and clearly the program is a lot more than just inpatient hospital. It's also, if the pies were bigger, they should be much bigger over time. You can see that it's growing from just under 1% of GDP in 1976 to more than 3.5% of GDP in 2016. We'll talk a little bit about continued growth in GDP in a little while, but I'd like to start with this as a demonstration for, although would have been impossible in 1976 to forecast, the construction of that pie, 40 years down the road. It's still actually very important to measure and estimate and evaluate what the anticipated effects are of current status, current program. A lot of the reason why this pie looks different is because legislation has changed over time, and the program has matured and has evolved, and will continue to do so. But stopping annually and evaluating the current financial status is actually a pretty important process. One of the reasons why we've seen these changes is just this very large change and shift towards private plans. This is really looking at Medicare Advantage penetration rates over roughly a 25-year period. You can see that the rate of Medicare take-up has been growing very steadily and is forecast to continue even more so. This has a lot of detail on it. This just kind of highlights that when we're talking about Medicare, there are two separate and distinct trust funds and two really separate and distinct almost benefits within just the medical portion of the program. The HI hospital insurance program provides mostly inpatient hospital care and other skilled nursing, home health, hospice care, so more institutional settings. And supplementary medical insurance is actually two separate accounts there. There's the Part B, which has the physician services, outpatient, home health, but also has the Part D account. One reason why it's important to keep the programs separate or to evaluate them separately is that the financing is extremely different between the two. The source of financing for HI is payroll taxes. There's the amounts are included in a trust fund, and there's no authority to provide benefits to the extent that there's insufficient funds available in that trust fund. What gets the most attention each and every year in response to the trustees report is that data depletion of that trust fund. We'll talk about it in a little bit, but that's not very far off into the future. In this year's report, it's 2029. As compared to on the supplementary medical insurance side, those are financed via general revenue transfers and beneficiary premiums. Those financing rates are set on an annual basis, so they are effectively always in financial balance. And so when evaluating the status of those programs, it's more important. The fact that they're always in financial balance means it's important to consider the other impacts of such spending, such as share of GDP, share of federal income taxes, proportion of individuals, Social Security checks, and all those things are captured within the report. So the foundation of the projections always starts with evaluating the new experience, and so this is a comparison of the 2017, the expectations, the projections of 2016 Medicare experience between the 2017 report and the 2016 report. The income is generally forecast by or projected by our counterparts in the Social Security Administration, and is generally subject to less variation than that of the expenditures. 2016 was a good year to be an actuary, at least an actuary in the Medicare office. It is pretty remarkable to see differences in expenditures as small as these. The fact that expenditures on HI were 1.7 billion lower than expected, still good news, but on Part B side we're almost exactly in line, 0.3 billion higher than expected. On the Part D side, the expenditures were somewhat lower. I'll talk a little bit about that, but Generally, there's been some more favorable experience on the Part D side after a couple of years of higher costs associated with, in particular, specialty drugs, most notably those that treat hepatitis C. So this looks at the income and expenditures. It kind of builds up from the payroll taxes. Payroll taxes are set in statute to be 2.9% that are of payroll of income, and that amount is fixed in law. That 2.9% is split between employees and their employers. If self-employed, pay both portions. There's also an additional amount of 0.9% that are paid by high income earners. So those that are over with incomes over 200,000 individually or 250,000 joint filers. That has gotten some attention recently. There's also tax on Social Security benefits that reflect a portion of the income that goes into the HI trust fund. And then building up, there's the premiums, which are generally a large portion of both the Part B and Part D programs. There's some state transfers and drug fees that mostly go into Part D. The general revenue transfers, that's the federal matching on Part B and the contributions on the Part D program. And that line up top, the gap between those build up and the total expected expenditures, which max out at roughly 5.9% of GDP. The gap there is the deficit. And so that is the amount of expected expenditures that the programs would be making, most notably for HI, after, and the deficit reflects the amounts, the gap between those spending from current sources of revenue versus what would be available in the trust fund. And so that's the deficit that would need to be made up in order to pay full benefits if all assumptions are realized, and we'll talk a little bit more about that. So the formal status of the trust funds, as I mentioned earlier, has to evaluate both the HI and the SMI funds separately. The key questions to answer on the HI are assets plus projected income adequate to finance anticipated benefit costs. And on the SMI side, the fact that there are the financing is set annually, both for Part B and Part D. There's no long-term solvency issues, but there are other measures that are informative that we'll summarize. We'll also note that the projections in the report are mostly on a current law basis, and there are some potential aspects of current law that might prove problematic to maintain indefinitely into the future. As I said, these are 75-year projections, and the two in particular that I'll note are, one, the productivity cuts. These were associated with the Affordable Care Act, and that says that basically the payment updates for most non-physician providers will be reduced by economy-wide productivity. The issue here is that productivity that can be achieved in the health sector has historically, and we anticipate in the future, is less than what can be achieved in the economy more broadly. To the extent that providers can't keep up with those payment reductions, the expectation is that there might have to be either reductions in access to care or quality of care or some other changes that would account for that gap. And again, that's only if the providers can't transition to become that higher level of productivity. For physician updates, the MACRA that was passed 2 years ago specifies all price updates for physicians in all future years. And so there's a transition period until we get to the point where either physicians are in these APMs or advanced, I lost it. What we got? APMs. Alternative payment method. Oh, excuse me. Thank you for that. Or in the merit-based incentive payment systems. And once they are there, all of the updates are at are specified in law, and these payment rate updates, so the prices that the price increases that physicians will receive, are specified in law to be 0.75% if they're in these alternative payment methods, or in 0.25% in the MIPS program. Those rates are specified, and they will be constant regardless of whether underlying costs for physician services are increasing at a faster rate. We anticipate that the underlying costs, as measured by the Medical Economic Index for physicians, is closer to 2.2%. And so that gap between what we think underlying physician costs are growing at versus what those payment rates will be updated by will become a concern over time. And so while there might be some inefficiencies that could be wrung out of the system over some period of time, we're concerned that over a long period of time that they could prove to be problematic. In response to those potential concerns, the trustees have presented an illustrative alternative scenario that demonstrates the potential understatement in current law to the extent that these provisions do not continue indefinitely into the future. And so there is the productivity transitions that transition to what would be experienced in the health sector. Physician updates are ultimately transitioned to the MEI, and basically, and the Independent Payment Advisory Board, the IPAB provisions are not implemented. Those are what's presented in this illustrative alternative scenario, which is included and referenced in the report as a potential understatement of current law costs to the extent that they cannot be realized in the future. So turning to the actual results of the report, here you can see that the HI trust fund ratio, which is a comparison of assets at the beginning of the year to the percentage of annual expenditures. The objective here is that the short range objective goal is to achieve 100% for all years. You can see that we are clearly below that level today, and we are projected to actually become depleted in 2029 this year. And that is 1 year later than what was experienced last year. You can see that the general shape of that curve hasn't changed much, but the fact that we did get some favorable experience in the HI Trust Fund, most notably lower 2016 expenditures and somewhat reduced trend rates for inpatient hospital in the very short term, have contributed to that lengthening of the depletion date. You can also summarize the status in terms of an actuarial balance. And this looks at the present value of income rate, so all of the dollars going into the program, less the cost rate, all the dollars going out for benefits and other expenses, compared to taxable payroll, so the base by which most of the income is generated. And you can see that income rate rarely changes very much from year to year. And you can see that there was this slight improvement in the cost rate. As a result, the actuarial balance has improved. There is less of a deficit this year. So effectively, this actuarial deficit of 0.64% means that if the current payroll taxes of 2.9%, if those were increased immediately today in 2017 to 3.54%, the trust fund would be in financial balance for over 75 years. So often this is more interesting when there are bigger changes. You can see that there are not many differences. This is basically just a walkthrough of what the differences are between that deficit from 2016 report and the 2017 report. And you can see that the largest contributor here is the hospital assumptions, so the 0.8%. So looking at the long range, so here is the annual representation of what's happening on both the income and the cost rate. there's a couple of things to note here that you can see in 2029 that basically there's that line that drops from the cost rate down to the income rate. And that really represents that when assets are depleted, the only amounts of funds that will be available are the amounts that are actually coming into the fund. So in 2029, we estimate that income would represent 88% of the needed funds to provide benefits. And you can see over time that those ratios change over time, but it's roughly in those mid to upper 80s. You also see that cost rate kind of bounces, actually gets closer to the income rate over time and then kind of stays level there. And that's partly, again, due to some of those productivity offsets. And I think the next slide will this one first compares the cost rates from year to year, but this one adds in what those cost rates would look like under the illustrative alternative assumption. And you can see that those productivity offsets, which are roughly 1.1% as compared to what we think could be achievable in the health sector of roughly 0.4%, starts off, if you only look through 2027 or look through 2040, those gaps are not very large. But you can see that as you compound out these differences over time, in particular over 75 years, those differences get very different. You can see that that cost rate, while it is currently in roughly the 5% range, would max out over in excess of 8% just for HI under that illustrative alternative, which just kind of highlights what the importance of actually of providing those alternative projections. As I mentioned on Part B in particular, SMI in general and Part B in particular, the rates are financed adequately, so you'll always see that the income is going to be very close to what we project for expenditures. So in terms of evaluating financial status, there's not a lot to show here, and what you can see is that the 2017 is slightly higher than where it was for the 2016 report. So a little more to the story here in Part D. There was a notable reduction in anticipated spending and actually achieved spending in 2016 on behalf of, with respect to hepatitis C related drugs. And there was also a significant increase in the amount of manufacturer rebates that were coming into the program. These two factors contribute to a significant decrease in the expected expenditures for the Part D program. So this was actually a pretty significant change in what we were experiencing in Part D. This just summarizes both B and D program together, and you can see again under current law, we are currently at something a little in excess of 2% of total expenditures of GDP. That's expected to grow to a little less than 4% of GDP, by the end of the projection period. Again, looking at the changes, this is pretty much just another way to look at what was summarized previously. Not much change on the 2016 as a percent of GDP, but in 2090 there was actually some. The Part B is slightly higher, and the Part D is somewhat lower. And again, the comparison from this year's report to last year's report again shows that this year's report is slightly higher on B. Importantly, this one looks at Medicare expenditures in total. Again, comparing that current law to the illustrative alternative, and it really just demonstrates that even though when we are looking at, under a current law basis, a Part A program that has an actuarial deficit issue, is expected to be depleted in roughly 12 years' time. To the extent that current law provisions are not able to be implemented, and on a Part B and Part D programs that show a largely increasing share of those programs as a share of GDP and other relative measures. Those potential troubling results could actually be a lot worse to the extent that current law provisions are not able to be implemented completely over time. And you can see that the magnitude of those differences are actually quite substantial. Under current law projections, Medicare expenditures are expected to grow to 5.9% at the end of the period, end of the 75-year period. But under the illustrative alternative, they're expected to grow to 9%. So the Independent Payment Advisory Board has gotten a fair amount of attention. In last year's report, it was expected to be triggered in the 2017 report. It did not happen this year, in part because of some of that favorable experience in the program. But just to kind of take a step back, must make a determination each and every year whether the Medicare rate is going to exceed a target rate that's specified in law. For each year that we've had to do so, the target rate has not been exceeded. So the IPAB has not yet been triggered. So basically, the comparison is looking at Medicare cost growth rates for the 2 years prior to the evaluation and 2 years post-evaluation, so for a total of a 5-year period. The Medicare growth rates are compared to a target, which historically was based on CPIU and medical CPI. Looking forward, it's going to be based on GDP plus 1 measure. If the Medicare growth rates are greater than the target rates, then I must certify what that savings target is, and that must go through a process by which an approach, proposals to actually reduce spending would be implemented to do so. In the 2017 report, in the current report that was just released, we are projecting that the IPAB will be triggered in 2021. However, in that year, if you actually look at the report, that goes to 2 decimal percentage points. It's identical there. You actually have to go out 2, 3, or 4 decimal points. So needless to say, it's on the razor's edge, and there's a very good chance that that would not yet be triggered even in 2021. However, it will get evaluated on an annual basis. So just here's a summary. Changed a little bit, but basically we are comparing the Medicare growth rate this year, the 0.4%. Excuse me, there's supposed to be a circle around 2015 through 2019. And in doing so, if you were to average the 2, the 1.1, the 0.4, 1.5, and the 5.7, you would get the 2.14%. You compare that to the target of the 2.87%, and that's why the IPAB was not triggered this year. You can see here in 2021, we do have the comparison 495 to the 495. If you go out a few more decimal places, the Medicare figure is slightly higher than the target. Looking at the Part B premium, the Social Security cost of living adjustment is projected to be 2.2% this year. In response to that, largely in response to that, there is the expectation or the forecast that the 2018 premium will be projected to remain at $134. Roughly 70% of beneficiaries have been held harmless in 2017, and in fact have seen pretty modest increases in their Part B premium since 2013. The premium rate was actually flat for a number of years at $104.90. And then a number of years, in 2016, there was a 0% cost of living adjustment, which meant there was a large number of people that were held harmless. In 2017, there was a 0.3% COLA, which meant that individuals experienced a small increase in their Social Security checks. This hold harmless provision specifies that individuals cannot see a net reduction in their Social Security checks due to an increase in the Part B premium. With either low or no increases in Social Security checks, many beneficiaries, roughly 70%, were affected by that provision. So on average, we were expecting that these people are paying roughly on average $109 this year. We are expecting that gap between the current amount that these individuals are paying, the $109, and the current premium level of $134 to narrow considerably when there is a substantial, or certainly a more substantial cost of living adjustment that is forecasted for 2018. However, despite receiving a significant cost of living adjustment, many, actually most, will not actually experience a net increase in their Social Security checks because they have, for the fact they've benefited from the hold harmless provision for a number of years now, that gap will be made up largely in 2018 with that cost of living adjustment. And so I wanted to end with almost where we started. And it started with a comparison of how these programs have changed over a pretty long period of time. We often look at individual trends and individual rates of change and individual comparisons to what was projected. This is a comparison. I apologize if it's difficult to read the bottom there. But basically, this is looking at the changing share of Part A fee-for-service benefits over time. Starts at 2006 and ends at 2025. So a 20-year period. The blue bars represent the largest component of fee-for-service Part A spending, which is for inpatient hospital. The orange bars reflect SNF, skilled nursing facility. Yellow, the gray is hospice, and the 4 is home health. Is it all home health? That's right. So the inpatient hospital, which is obviously and is still the largest share of Part A spending, or Part A fee-for-service spending, has changed quite substantially over a relatively short period of time. And really it's attributable to both the growth in skilled nursing facility and hospice. But that's not really telling the full story there. I think largely what's driving this phenomenon, you can see that what I'm trying to illustrate here is how do those programs change so dramatically over a long period of time? And the answer is that they change really slowly each and every year. And part of what's happening here is that what we've seen over a number of years is that a large number of cases that would have otherwise been inpatient have moved to outpatient. And we'll see that on the next slide when we look at Part B spending. And so if what's remaining in Part A in true inpatient experience is the more severe cases, those cases that could not be treated in an outpatient setting, what's remaining are the shares of care that are more likely to result in a SNF stay afterwards. And so you can see that shift over time. You have the aging of the population, so you have some shifts in policy towards increased hospice care over time. But I think largely what we're seeing here is that shift from inpatient to outpatient. And then we turn to Part B. You can see a similar comparison here. Again, looking, the blue bars are physician, the orange is outpatient, gray is durable medical equipment, and the yellow is all other. You can see that the largest share, 10 years ago was physician. That's no longer the case. The largest share of Part B fee-for-service, or it's no longer the case in the forecast when we get to 2026, that there is a large and growing share that's attributable to outpatient claims. So we think that shift is going to continue. And you can actually start to see some of the effects of some of those payment rate updates on the physician side towards the later end of this particular projection. It's a little more subtle is on the DME side, is you can actually see that there was a pretty sizable reduction from 7% down to 4 or 3% over time, which shows the effects of some of those competitive bidding programs that have been implemented around durable medical equipment. And so for as interesting, and I'll take if your opinion on how interesting this is different than mine, how interesting those might be, if we look at Part D, and this is going to be my last slide, the differences here are pretty striking. This is comparing, the blue bars are direct subsidy, the orange bars are reinsurance, for federal spending for basically catastrophic claims. And what this shows is that in 2006, almost 3/4 of the benefit were direct subsidy spending. Direct subsidy spending is I'll call it the value that's attributable to, the general Part D benefit. The benefit is split into several different phases. In the end, in the catastrophic phase, after an individual hits their out-of-pocket limit, the benefit changes significantly, and the funding of it changes very significantly. 80% of catastrophic spending is funded by by Medicare, directly, as compared to the standard benefit is funded 75% through the plan bids, and 25% is beneficiary cost share. So how this benefit has changed so significantly over such a short period of time really demonstrates how the changing landscape of prescription drugs, in particular prescription drug pricing, has changed over time. People are getting similar amounts of drugs that they always have. What's changed is that the vast majority of the most common drugs are now generics, and those generics are relatively low priced. And so there's been a decrease in that aspect of the benefit. Where there's been significant increases is on the higher cost drugs, on the specialty drugs, most notably over the last several years around hepatitis C drugs. There's significant costs associated with those, and what we're seeing is that there are relatively few people generating a large portion of those ultimate spending. What this means in terms of impact and potential impacts for policy is that there's just the broad value that individuals were receiving in the Part D program has shifted, where many were getting very good value out of that coverage, to the extent that the value is now centered towards those that are just using these high-cost drugs. Is something that policymakers really need to be aware of and take seriously and take into consideration. I know MedPAC has done some work on here and has some recommendations as to what could and should be done around this. But this is just something, an interesting way to kind of look at the changing market around prescription drug benefits.
Okay, thank you, Paul. On that last slide, one of the other aspects that you didn't mention was the change in policy, though, to close the so-called donut hole, which also, you could see that step function. It's not solely pricing; it's also policy that's driving part of that.
Somewhat. There wasn't a huge change in the number of people getting to catastrophic coverage in response to that. And if anything, that would have dampened the effect that there might have been more people getting more coverage, more value throughout the benefit. And the fact that we've kind of seen that catastrophic continue to increase as a share, I think the issue remains. But yes, the closing of the coverage gap certainly provides more coverage to more people earlier in the benefit phase, but not sufficient enough to actually offset the effects of those high-cost drugs.
Right. Okay. So Maya, take it away.
Okay, thank you. Thanks, Joe. Thanks to AEI for hosting the event. And Paul, I thought that was a really good presentation. There was so much information in there, and great overview of really complex topics. And I'll say something I was saying before we came here, which is I really encourage people to read the trustees' reports. I think it's a time where, with policymaking, we are losing touch with the numbers and the facts as good starting points. And so things like the annual reports of the trustees, things like documents from the Congressional Budget Office, they are so informative. And this is one of the ways I started to learn about Social Security and Medicare, was reading these reports every year. So I know it doesn't sound like a lot of fun for those of you who haven't already read them, but you learn a lot, and they're great, and they're impartial, and they're very useful. So I'm going to take a step back, and I'm going to talk a little bit about healthcare in the overall fiscal situation that we're facing, and a little bit about our environment for dealing with these things. And I'll be brief because I'm looking forward to having a discussion. But just as a starting point, our overall fiscal picture in this country is on an unsustainable path. Much like the kinds of warnings we hear about Social Security and Medicare, our big entitlements, our debt picture in this country is on an unsustainable path. Our debt relative to the economy is the highest it has been since World War II. And the difference is that after World War II, it quickly came down and came back to closer to historical averages, where we are on track, where the debt relative to the economy will be growing indefinitely, faster than the economy. That is unsustainable. That is undermining of any healthy economy. And in many ways, I think it reflects kind of a broken political system where we no longer are really willing to confront and tackle these very difficult challenges that require hard choices. So if we do nothing right now, the debt, which is 77% of GDP, is on track to go up to about 91% of GDP 10 years from now. We'll basically, again, making no policy changes, borrow $11 trillion over the next 10 years. And kind of hard to picture what 11 trillion is, but suffice to say, that's too much money to have a plan that that's what we're going to be borrowing over the next 10 years. And so the key is, how are we going to get a hold of these problems? Really, the biggest issue in all of this is healthcare. The healthcare costs are the single biggest challenge because they so are the drivers of the growth of the debt, along with the aging of the population, and because it's really complicated. When it comes to something like Social Security, which is the biggest program and desperately in need of reforms, as is Medicare, we kind of know how to do it. There's about 5 variables which we can make changes to, which are not that difficult from a policy perspective for how to make a fix. I actually remember when I was in graduate school, I went to graduate school to focus on budget deficits, and right when I was there, they got the deficit under control. So I was like, uh-oh, no problem to worry about. And then, lo and behold, you study a little bit more. These long-term challenges from Social Security and Medicare are still looming out there. And so I spent 2 years in public policy school, and I quickly decided I was going to become an expert in Social Security because it was so easy to fix, and I was going to leave the hard ones to other people. And you can't be a fiscal policy expert without focusing on healthcare, but this one really is the more difficult one. We don't know all of the policy solutions. I think that's why it's even more important to get started on putting in place reforms to control costs as quickly as possible, because as we have been for the past years, we're going to continue to have to try to see what works, figure out what's working best either in the states or in pilot programs, and then implement more of those changes. But Medicare is a huge key to all of this. It's the second largest program in the federal budget. It's about 15% of the budget, and it is one of the fastest growing programs. So over the next 10 years, it's going to account for about 30% of the programmatic growth in the budget. Over the longer term, healthcare costs pretty much account for all of the growth, all of the non-interest growth in the budget. Interest is actually the fastest growing part in the budget right now. But healthcare costs account for pretty much all of the long-term growth. Medicare is about 80% of that. So there's just no question that what we need to be doing is focusing on reforms. And every year when the trustees come out with their reports, they warn us that you do need to make reforms. The sooner you make them, the easier they are to make. And there is absolutely no reason to be putting them off other than from a political perspective of that it's hard. To talk just for a minute about the political environment, I think one of the troubling things is that right now, really the willingness to confront hard choices between and including with both parties seems to be at the worst point it's ever been. I feel like I say that every year, but it then proceeds to get worse. It is the worst point every year, and then the next year is worse. And this really is a terrible moment where the partisanship is so deep, so high, and the way that both parties are competing is saying, I'm not going to do a single hard thing. And just if you look at the overall budgetary situation, we have a president who ran on saying, I'm not going to touch Social Security and Medicare, made promises not to touch those programs. If there's anything we know, you do have to make reforms to them. It is perfectly legitimate to have very deep differences of opinion about what reforms, what changes to make to fix those programs, but the notion that you don't have to make changes to them is just not rooted in any reality, any policy reality, and it really jeopardizes the programs for the people who depend on them. So I think that's a real problem. I think in the healthcare debate that we've obviously been enmeshed in the past months, it's been much more of a political debate than a policy debate. I sort of think starting at first principles of, okay, we're going to repeal and replace Obamacare, and I don't have a position on whether we should or shouldn't. But the first question is, what are we trying to solve? And I feel like many of the policymakers involved in this question couldn't even tell you which problem it is that we're trying to solve. I will tell you one that I believe and our organization believes we should be spending more attention on is how are we going to control overall healthcare costs? And that's different than just saying you're going to pay less for healthcare. It's creating a structure for a system that will do more to incentivize controlling healthcare costs than what we currently have. We didn't think there was enough of a discussion about that when we created Obamacare, and there's definitely not enough of a discussion about that right now when we're talking about options to replace it. It's certainly in there. Sometimes there are pieces of it that could do it, but it's not the central piece of what's motivating healthcare reform talks. And given those numbers, given the scope of healthcare in our budget, how that undermines potential for economic growth in our economy at a time when we really need it, it should be front and center more than it is. So I'll just touch upon a couple of the areas I would like the healthcare and Medicare debate to be talking more about, and then I'll turn it over to Jean. I think the key is going to be looking at a couple of factors. The first one is delivery system reforms, doing more for how we deliver healthcare in terms of creating payments for quality of healthcare, payments for outcome rather than what is provided. So bundled payments is the kind of option. Accountable healthcare organizations, figuring out what's working there, figuring out what we can do more of. But it really is creating different structures in the delivery system. A second piece of this is certainly the incentives within the healthcare system. We are still to this day very much too removed from the overall costs or prices of healthcare, so there aren't the right incentives aligned. And insurance is always a complicating factor in that because there is a very critical role for insurance in terms of insuring people against excessively onerous healthcare costs, but at the same time, you don't want to insulate people from the price completely. So there are things like first dollar coverage, which can undermine price sensitivity. You probably want to limit supplemental insurance. How HSAs can be used in different ways that can be very useful depending on what the money is allowed to be used to pay for. And I think transparency in pricing. This is so long overdue in our healthcare system, but figuring out more transparency in pricing of healthcare is a critical component of this. I just put out two others: tort reform, so that we do more so that there's not excessive preventative providing of healthcare to avoid lawsuits, but that it's more about health. And finally, the tax treatment of healthcare. We subsidize health insurance through the tax code, through the healthcare exclusion in a way that economists on all sides of the aisle agree is inefficient and drives up the overall cost of healthcare. That would be a great policy to look at to limit the healthcare exclusion, which could provide more revenues to shore up the healthcare system, to bring down the debt, a whole lot of things. And it's one of those rare twofers right now in policy where it would be good tax treatment and a tax policy, and it would be good healthcare policy. Actually, it's a threefer. It would also be good fiscal policy. I'm always wary of whenever people say that something's like a win-win, because it usually means they're trying to sell you something for free when it comes to budget policy. But I think looking at the healthcare exclusion could, in fact, be a win-win-win. So I'm going to end by just saying this is the details are so important, and the big picture is also so important, which is we are on an unsustainable path. We have a political system that is utterly unwilling to come to terms with that and put forth any real policy solutions that will grapple with that. And the biggest key in all of those policies is going to be healthcare reform. And as we are fighting it out, I mean, I just think the quality of the discussion around the healthcare debate in the past months has been terrible. It has been a disservice to anybody who's trying to understand healthcare policy and think about what is true, that there are trade-offs. There are trade-offs in things, and we have to figure out how much we want to subsidize a variety of different things and who should do the subsidizing and what the structure of the pay-for should be. We're not having this discussion in a realistic way at all. And I think that's really the first step for starting to come up with some smart policies to tackle these admittedly difficult but critically important challenges. And so again, there's so much great data in here. There are so many numbers. Anyone who likes spreadsheets, there's so much stuff to play with in these trustees reports. So thanks for the presentation. Thanks for the panel, Joe.
Thanks, Maya. Very good points. I mean, it's certainly the case that most of the Sturm und Drang that we're experiencing these days have nothing to do with the single biggest program, at least generally speaking, in the United States, or at least the one that has the most leverage on the rest of the health system, which is Medicare. While it's certainly true that private insurance, private healthcare delivery, and the Medicaid program have great influence. The reality is that a lot of what Medicare does in terms of its regulations and procedures shape a lot of what goes on in the whole rest of the health system. And so your points are highly relevant to this discussion about the Medicare Trustees report. Gene, please.
Well, thank you, Joe, and I'm honored here to be on this illustrious panel. I've known everybody on this panel for a while. Paul, perhaps the least, but I'm really glad to get to know you, Paul. And let me also add to Maya's compliments on the work of the actuaries. And it's not just the trustees report. We have certain offices in this town that are highly informative, extremely professional, and have a great deal of integrity. They include the actuaries office for both CMS and for Social Security. They include offices like CBO, Government Accountability Office. I think it's extraordinarily important that not only we maintain these offices, but really we strengthen them. They are the sources of information we need to help the public sort out its own decisions. And so thank you, Paul, and thank your colleagues. And also like to thank AEI. Actually, I've done a number of these panels before, not one recently, because you keep taking Bob Reichard, my colleague at Urban, who is also a trustee, or has been a past public trustee, among other many illustrious titles. But also, some of what I'm going to present today is something I originally did for AEI many years ago. I want to concentrate a bit on the relationship of health to everything else that's going on. So in some sense, it's correlated with what Maya already presented. And in that sense, I'm reminded a bit of some of the announcements that used to be made in church and synagogue bulletins. They were correct, but they give you a slightly different focus depending on how you think about them. So for instance, one of them was, please put your contribution in the collection basket along with the person you'd like remembered. And another one was the bulletin said that Margaret McGillicuddy sang, "I will not pass this way again, much to the delight of the congregation." And then another one was, the youth will be performing Hamlet today in the basement. Please come early and watch this tragedy unfold. So in some ways, I'm going to be taking some of the data that I've got on Medicare, and it's actually going to be some of the same emphasis as Maya did, but to argue, and Joe reinforced this point, to argue that you really can't talk about Medicare in isolation. You know, if maybe there's a fire on the street and your roof's caving in, but you can't just focus on fixing the roof. You've really got to worry about the system, and it's also partly because in the budget we make allocative decisions. A lot of times we talk about budget. The unfortunate thing is people often think of budget policy as just deficit policy. Well, as long as we get it in balance, and trust funds tend to give you that same message too. As long as we get these things in balance, we don't have a lot to think about. I mean, basically, the budget is how we allocate. If we decide we're going to put $1 in Medicare, we're not putting it somewhere else, or we're not raising taxes to pay for it. Just as if we put the money into education, the same thing happens. And so you have to think about what we want to do in Medicare with regard to how we allocate everything. And so let me jump quickly to my slides. And basically, they're going to make 4 points in these slides. One, that health dominates. So recently, I've been doing a lot of work, not just on, say, how much of the budget is in healthcare, or how much of national healthcare spending is on healthcare, but the increments of the growth we have in the economy, or the growth we have in government spending, where is that going? Because those increments are usually where we make most of our marginal decisions. We usually tend to do some of the same things over and over again, but it's the increments, it's the growth that we allocate. And so I'm going to focus on those issues. And as you might guess, health dominates the growth in federal spending, and Medicare is the flagship there. My second point is, if you look at health and Social Security together, the growth in health and Social Security and Medicare of about $1 trillion 10 years from now relative to today, that's a 1-year number, that's not a 10-year number, basically is in excess of all the growth in revenues that we're expecting, even if we don't have a tax cut. The third one is that generationally, we're giving youth a lot, but only when you retire. So we're asking you to pay a lot more for your higher education. We're going to cut back on your support as workers. We're going to support your children less, and a lot of other things. But don't worry, down the road, we're going to give you a lot more Social Security and Medicare. That's what the system says. I'm not sure that's the bargain you want. And my last one is is that if I even go beyond the budget and these issues and I look at the growth in the economy, healthcare is totally dominating the income growth in the economy, and it's distorting our sense of even what's happening there. It's distorting measures of income distribution and all other sorts of things. So now I've got to quickly go through these slides. I call this Medicare versus everything else. This first slide shows you the growth in all the non-interest outlays of the government. Now this is a year old because I don't have all the updates yet, but this is CBO's estimate of where the real growth in spending takes place. By the way, CBO doesn't measure real growth, it measures nominal growth. I had to convert it to real growth. But real growth in spending here is about $1 trillion. And of that real growth in spending, say 2026 versus 2016, 38% of it goes for Medicare. So Medicare by itself would absorb close to 40% of all the growth in spending for everything other than interest on the debt. This is government spending. And then if I add in other healthcare spending increases, it goes to 55% or so. And by the way, this confirms something Joe mentioned a minute ago. We're having this big debate over ACA and not over things like Medicare. If you look closely at the numbers there, the ACA expansions, they're causing a growth in spending of about 8%. That is, they've got about 8% of all the growth in spending, whereas Medicare's got 38%. So it's maybe 1/5 the size. Mm-hmm. And then if you take Medicaid before we had the ACA, the Accountable Care Act, that's got about 10%. Right. So that just gives you a relative standing of how all these issues stack up and just how Medicare's dominating the growth in federal spending. This slide shows you Medicare plus Social Security. The second bar there is Social Security, Medicare, and other health, and you can see that the total increase in spending there. Now this is an updated number because I did have some new CBO numbers. The total growth in spending 2017 to 2027 now, I'm bumped up a year. 10 years from now, about $1 trillion more we're supposed to spend on these programs, and that's in excess of the revenues, the additional revenues that we're expected to get. So after we spend all this money, the revenue growth on this growth, we still got to cover all this growth in the net interest on the debt, and of course everything else in the budget basically is essentially getting zero. That's mainly the discretionary non-defense and the discretionary defense spending. That's what our current budget says we will do. It's not the decision of current policymakers. That's the path we're on. My third slide here basically shows you that this is not just an issue having to do with the fact that the birth rate fell and the baby boomers are retiring. This gets to my point that I mentioned earlier to young people in the audience. We are promising you something, just got to wait till you retire. Because the average couple today, this is basically the 2015 set of numbers. Is probably too much in this graph, but the 2015 set of numbers, ends up to be the fifth column in this chart, says that we give about $1 million in Social Security and Medicare benefits to an average income couple retiring today. That's what they need in a 401k account, earning a modest real interest rate to be able to pay for their benefits on average. Again, for you millennials, $2 million. You know, we're gonna double that, and it's now. By the way, this has nothing to do with the decline in the birth rate. This is just the built-in growth due to the fact that health. We keep going to finance more and more health for you. We're going to give you more and more years of benefits in both Social Security and Medicare, and within Social Security, which we're not really talking about today, it's also wage index. That is, if your wages are 30% higher than ours are, you're going to get 30% higher annual benefits. Now, I'm not saying some of those things wouldn't be good to do, but remember, we're doing this instead of everything else that we're almost doing in the country. And basically, this simple graph on an individual basis pretty much summarizes where all the growth in government spending is going, although it doesn't have the Medicaid in there. And then finally, the final graph that I mentioned is, if you look at the blue bar here, this is a very crude measure of something people call excess cost growth. So excess cost growth is sort of this notion, well, let's measure the growth in healthcare cost in excess of the growth in GDP. The only adjustment I made here is I did it on a per capita basis. So what's the growth in per capita health cost relative to per capita growth in GDP? And what you can see, all the little blue lines down there, is this says, well, the growth is maybe a little less than 2%. And there's this debate about whether it stopped or started or anything else like that. I've been proposing for some time now that that's actually the wrong way to measure what's happening with health cost growth, not only measure, but to predict it, or at least project it. So what I calculate is what's the growth in income, that's the share of income growth per capita that's going to growth in health spending per capita. And those are the yellow lines, which says that for every dollar of increase income we've had in this economy, about 32% from 1990 to 2007 has gone for healthcare. This is healthcare including private and public, although the majority is public. If you take the period from 2007 to 2017, admittedly including the Great Recession, health has got about 60% of all the income growth. And if you take the CMS projections going out into the future, or I could call projections, that's probably the wrong number. I'm not quite sure. We never know what to call it because we're not really forecasting. But you still get a number of about 50%. Now, part of that's because the income growth in the economy is projected to be low. So if health keeps spending more and more in real terms and the economy's not growing much, then it's absorbing huge portions of it. But this measure tells you that even when we're thinking about people complaining about what's happening to their wages, what's happening to their compensation, other issues like that, it's healthcare that's a huge part of the story, and people don't count that. They often don't count that as part of their income growth, and it distorts all those debates as well. So those are all the slides that I wanted to do. And again, I just want to return to this notion that Medicare is in many ways the flagship of much of what you're seeing here. And you have to address the flagship. So this, for instance, I don't know if people have noticed it, one of the big debates right now in the Accountable Care Act is should payments price inflation or should it grow at the rate of medical price inflation? Well, in point of fact, if we keep medical price inflation continuing as the current system does at this rate, and add on to that the new services we get, which is the quantity on top of the prices. This is reflected in a lot of Paul's comments about are we on one path or the other. It's an unsustainable path. But to think that we're going to solve this just by looking at Medicaid and just demanding it or demanding that the state somewhere or another make an adjustment doesn't make sense. You've got to deal with the system in a much broader sense. And in that sense, the place in terms of government you have to look as much, if not more than any place else, is Medicare. It is the flagship. Thank you.
Thank you, Gene. Your last comment brings to mind a well-known fact, the comparison between the U.S. health system and most European systems. We spend a lot more than European systems. I won't get into the details of whether we're getting value for it. There's some debate about that. But what's the big difference in the spending? It's not utilization. It's prices. So that enhances the point of this chart, that it really is prices that's driving it. If it were utilization, we might have a different view of this. We're just spending more money. Bob?
Well, thank you very much. First of all, I want to add my positive comments to those of my colleagues concerning the performance of the Office of the Actuary of the Medicare program. I'll say publicly what we've said privately to each other. In terms of fairness, in terms of making sure that they don't put their fingers on the scales of justice when they're evaluating matters, they have been absolutely first-rate, professional, and have done a fantastic job and have really shown what it is to be public servants. I'd also reaffirm Maya's point about the incredible value of the annual Medicare Trustees report. It is a rich mine of great information, statistical data, and analysis that you can use throughout the year. Many of us in the policy community use it. I do wish, as Maya has pointed out, that I do wish that members of Congress would actually pay a little bit more attention to this. I do have a couple of process points I'd like to make before I get into some of the substance of this conversation. This year, this report is signed only by administration officials. The two public trustees' positions are vacant. This was true last year. So what that really means is, as good as this report is, it means we don't have any independent assessment of the financial status of the Medicare program outside of government officials. I think that is a problem. And I think that is a problem that both the President and the Senate have got to start to deal with rather quickly. We can't have this next year. This says nothing about the integrity of the report, but the fact of the matter is if you want to build public confidence in a report, you do want public trustees. The second issue, again, it's a process issue, but I can't ignore it, and that is there's a law on the books that says that the trustees' report is to be delivered on April 1st of every year. It is now July. This is becoming a problem. This is a law. This is not a good idea. It's not a suggestion. It's not, it's not something that somebody can get around to, at some point. What this really means is we have a law that is not functioning in this respect, and if the law is not functioning, we got to repeal it or change it. Now, there's a lot of things we could do. It's possible that, frankly, given the scope of the work that the trustees have to perform, that they actually can't do it in the time that's allotted to them. But I think what we have to do is Congress has got to look at this and say, well, is there a better way of doing this? My suggestion would be that they submit the report when the budget, the president's budget, is submitted. So Congress will have a chance to deliberate on this and make some decisions, especially if, in fact, they have to make those decisions based on excess dependence, for example, on general revenues, which, in fact, the trustees say this year they have made the determination that that is the case. Another observation about this, all right, so we're going to have the insolvency date at 2029. Last year it was 2028. That's no big whoop. The fact of the matter is the Medicare Trust Fund has been facing insolvency since I was able to read. I don't understand why the press puts the greatest emphasis on this issue of trust fund insolvency. The trust fund language surrounding this in the general media sometimes is really disturbing. They say, well, we're faced with bankruptcy. It's all scary language. But the truth of the matter is over the last 51 years, the trust fund has never gone into insolvency, and it's likely that it never will. It has to do, however, there is another problem, however, and that is that the difficulties with the trust fund that the trustees say, in effect, that a short-term evaluation shows that this is not on a sound financial basis, either short-term or long-term. They're right. That gets down to political leadership. Maya has mentioned this. I'll repeat it. We have a real problem. I'm talking about a major political problem, a problem of governance. And that is the political leadership in this country, Republicans and Democrats alike, are not willing to deal responsibly with some of the most important domestic policies facing this country, but primarily the management of the fisc, deficits, debt, spending, these issues. President Trump promised during the 26th campaign that he would not touch Medicare. The president seems hell-bent on keeping his promises. And of course, his first budget indicated that he was not going to touch Medicare at all. The paradox that we have here today is we're discussing a report signed by 3 cabinet secretaries who say exactly the opposite, whose sentiments are exactly the opposite. Page 9 of the report reads, I'll read it quickly, quote, the financial projections in this report indicate a need for substantial steps to address Medicare's remaining financial challenges. Goes on to say the trustees recommend that the Congress and the executive branch work closely together with a sense of urgency to address the depletion of the HI trust fund and the projected growth in HI and SMI expenditures. Well, they're absolutely correct. I think the president needs to have a conversation with his appointees about the responsibilities that they exercise as trustees of the Medicare Trust Fund. At some point, of course, there will be a day of reckoning, and the question of what we do with the HI Trust Fund is going to come due. We're either going to raise taxes or we're going to cut benefits in the Medicare Part A program. I would just mention for context that we have already scheduled right? Over the next 10 years, about $802 billion worth of payment reductions in Medicare under the Affordable Care Act. It's a lot of money. I've never seen, that's a big, big cut. Who knows? Thousands could die. But the point is that is on the table right now. In any event, Gene makes a vitally important point, which is something that has to be constantly, that we have to keep in mind, and that is the cultural environment in which we live is what Robert Samuelson once called, I think in a great book, called the age of entitlement. The government is becoming increasingly a mechanism where we transfer money from large classes of Americans who mostly work to other classes of Americans, mostly those who don't or can't work, based on various formulas of eligibility. The bottom line is that middle class entitlements are, as Gene points out, starting to crowd out other budgetary priorities. We cannot allow this to continue unless we are prepared to come face to face with a fiscal crisis. We are not going to, the trustees tell us, we're not going to face the IPAB machine this year. It's kind of like the doomsday machine in health policy, which is that if in fact healthcare spending, effective in 2018, if healthcare spending exceeds the gross domestic product plus 1%, the Independent Payment Advisory Board, which doesn't exist right now in reality, would recommend across the board or various types of Medicare payment reductions. In the environment in which we're operating right now, where we already have scheduled $802 billion worth of payment reductions, and under the alternative illustrative scenario of the trustees, they're saying that this could jeopardize access to care in the future. This means that we're going to have to make some very, very big decisions very quickly. We've got to get serious. My plea would be that we need our political leadership to engage in public education. Americans love Medicare. They absolutely love it. But the surveys show that most Americans are largely clueless about exactly how Medicare is financed, how much it costs, how it actually operates in practice, and it's a pay-as-you-go system. I mean, and Gene's work in this area is pretty important because there's a deeply held belief by a very large number of senior citizens that they are somehow or other financing Medicare coverage they're getting today based on the vague notion that the taxes they paid in their working life are paying for those benefits. This is a denial of reality. It's a very, very common perception. If it were not so widespread, it's the fact that it is so widespread is a very serious problem. I know that on a personal level, when I'm talking with even friends and relatives, people are loath to admit the truth that, in fact, no, they're not paying for their benefits. Medicare premiums pay only a small percentage of the total Medicare benefit cost. There is one thing I want to bring to your attention on the trustees' report before I turn it over to Keith, and that is on page 20 of the report, there's a discussion of Medicare Advantage growth. I think this is very significant. Last year, the trustees said that Medicare enrollment is steadily growing and will exceed 35% of total Medicare by 2025. On page 20 of the report, the trustees now say that Medicare enrollment will hit 36% of total Medicare enrollment by 2023. Medicare Advantage is growing a lot faster than a lot of other folks would have ever projected. Recognize the fact that since 2010, Medicare Advantage payments have been cut by about 12%. The Medicare market is very stable. The number of plans that are participating has been growing. There's been very little disruption. The patient satisfaction is enormous. And the thing that characterizes it more than anything else is that this is basically a defined contribution system. I don't think the formula that governs the payment is particularly good, but nevertheless, it is. And I think that looking at Medicare Advantage for the future it may give us lessons for how we can introduce some intense competition into the Medicare system based on something that is happening already. In fact, it may very well be that reality, once again, is outrunning the politicians, and we are going to see an evolution of a system that is more and more private over time than we have in the past. But once again, congratulations to the trustees for producing a wonderful report. And Paul, thank you for the very, very fine presentation and summary of it. Thank you.
Thanks, Bob. I want to go back to something you said earlier in your remarks. Apparently, you don't believe in the miracle of compound interest. Is that right? One of the we use the language, especially in government, to sell a program, and sometimes to make a point. And we can credit FDR with the insight back in the depths of the Depression. That if you're going to try to create some greater sense of ease in a very troubled country, that you need to use the right kind of language. And so when they created the Social Security system, they invented the term trust fund. Paul's going to say there is a trust fund, but a realist would say there's no trust fund. The money is collected; it goes into general revenues. The trust fund is an accounting concept. It's not a budget concept. But this is part of the problem. And this is one of the reasons why people think that they've already paid for it. Well, don't I have an account? I mean, I have a number, right? I certainly have a number for Social Security. I think people are a little less clear whether there's an account number, which turns out to be the same number for Medicare. But nonetheless, they think they have an account. They think they've paid into it for their entire working lives. And so therefore, surely I've paid for it. But as Paul's statistics have shown, and the trustees' statistics have shown for the last 50 years or so, that's not really true. Keith, take it away.
Okay, little segue there, Joe. So let me start by saying that, just associating myself with everybody's remarks about Paul and his team. And I had the distinct pleasure of working with Paul, his predecessor, and others there in the Office of the Actuary for many, many years when I was in government. And I cannot tell you how hard these people work. On top of the quality and the analytics, they're deeply involved in actually managing and running the Medicare program. It is one of the hardest working offices in government. They are there weekends, evenings, and nights, and they churn phenomenal amounts of high quality information. And in an age of alternative facts and the kinds of things we see around, I think Gene's points there about the value of institutions like CBO, the Office of the Actuary here, the Office of the Actuary at SSA, I mean, they're absolutely critical to what we need, and I just cannot tell you how much value I think they add. So let me make a couple of points, and the hard thing about coming last is so many of the good points have been made. I'll associate myself with some, hopefully correct one or two others. First thing I would say is one of the biggest pieces of news in this report, which we've kind of been sort of gone right past, is that the IPAB did not trigger. Okay, we've been watching this, and I think most of the analysts I know in the private sector had been predicting this was going to happen. Think about for a moment what would have happened had it happened. Okay, first is that a president who had said, I'm not going to cut Medicare, would have to propose cuts to Medicare. Remember that under the law, it doesn't matter whether the board exists or not. If the board fails to report, then the duty to report falls to the secretary. The secretary has to make proposals. If Congress fails to act, they get put into place. That whole mechanism would have played out and could still play out next year or the year after in a way that, for a president who likes to negotiate, could give him a certain amount of negotiating leverage, if you will. I fully expected, Joe to open this meeting with something provocative like, Paul, where is the IPAB body buried? He didn't. I was surprised by that. But we did have the opportunity to talk with Paul a little beforehand, and this leads to my second point. I mean, the most stunning thing to me here is if you looked at Paul's chart on per capita growth rates related to the IPAB, is from 2011 through about 2017. If I did the math right on a multiplicative growth rate, it's under 1% per capita. Is that about I always get worried doing math with guys that have PhDs in math, but I had my son help me last night, so. Yeah. I mean, that is really remarkable. Absolutely stunning that this year it was only 0.4% per capita. And that's largely, I think Paul commented, due to particularly inpatient cost declines, but other factors as well. And so that's my sort of second point here is, there's been a lot of debate about whether the Affordable Care Act is really to be responsible or not, and all those kinds of things. But the fact is, from 2011 to 2017, to see per capita growth rates under 1% in Medicare, like Bob, I've grown up 30 some odd years around this system, looking at insolvency around the corner and costs going like this every time I turned around. That's pretty stunning. So something is going on. We do not really know what, but it is a salutary thing, and let's hope it keeps going on. So the second point I would make, or third point I would make, is with respect to the long term here, and I agree completely with everybody's comments about not focusing on the insolvency date as the be-all, end-all of things. And I would say one thing to Joe about trust funds. A trust fund in a government concept is not the same as a trust fund in a private concept, because the assets are not set aside and reserved in the same way. All this is part and parcel of what the government is and does. However, it has functioned extraordinarily well in many ways as a fiscal disciplining device within the public context. So when we got up to, in 1983, I started my career in government working for the Office of Management and Budget and Social Security System, 1982. Social Security System was going bankrupt, right? And people had to do something. There was a gun to everybody's collective head. And they tried to deal with both the short-term and the long-term problem, and they did it by building in small and incremental changes over time, such as the increases in the retirement age that are now in play. My point here is that the trust fund things do matter in a way, and that's where Medicare becomes particularly complicated, because part of it is a trust fund, part of it's not. So while I agree, don't obsess about that date. It's not that the concept of a trust fund is not important in the public concept. It is. Second is, don't obsess as much about the long term either. I think Paul would agree with me that it's more for what it tells you about the dynamics and trends in the system. For example, the problems he points out with potential risks from productivity growth over the long term. And if I can segue here for just a second, I will tell you one thing that none of the bills on the repeal and replace, or whatever you want to call it, this week on the Hill, none of these bills would touch the productivity adjustments in Medicare. Okay, so they're repealing and replacing segments having to do with coverage. They're not doing anything with respect to the kinds of issues that Bob is raising about the productivity adjustments that are scheduled. So the long term is important, but it's important. I think my takeaway from this is good news in some ways in the short term, sobering news in the long term. But let me get to I'm going to join, I think, my colleagues here on the soapbox and say, you can't really just think about Medicare in isolation. You have to look at the whole budget picture. And clearly where Congress is, in my mind, is not focused on that picture. In fact, I would say the debt issue is a serious issue. And it is a difficult one for a democracy. Our history as a democracy has been one of struggling to figure out how to manage money, from the Articles of Confederation to through the anti-deficiency statutes, the budget statutes, the Congressional Budget Control and Impoundment Act. It's all about we try as a democracy to figure out how to manage money. This is part of that problem. I would say the one thing that people forget about the 80s and the 90s, and I lived through every OBRA, SOBRA, TOBRA, TEFRA, DEFRA, and IRTA, whatever it was, they were all the acronyms for the Reconciliation Acts back then, is that they were born of a bipartisan consensus that what was good for the country was shared pain. And I think Bob is the guy that's going to have the answer to this as the political scientist amongst us. But I think he is dead on that what we got to have is we got to have some people who say, look, we got to care about what we're doing for our country, and that Medicare plays a role in that as do, I would say, taxes, other spending, and everything else. It all has to be on the table, and we have to figure out what the right balance is to deal with the central issue of our time. And the central issue for our time is the aging of our population. You know, the declines in fertility rates mean that we are getting older, and we're going to continue to get older. And that has phenomenal implications, not just for healthcare, but for everything that goes on in this country. In fact, I'd say one of those issues, part and parcel to that, would be immigration reform. Now, it's far afield from Medicare, but if you're going to really deal with this problem in the way Maya in particular has framed this, I think all of that kind of thing has to be part and parcel of the discussion. It's not just about cutting Medicare or doing this. So I'm not the political scientist here, but I got to say, Bob, I think it was your point, this public education point. There was a man wrote a book back in the 80s, Daniel Yanklevich, called Coming to Public Judgment. He talked about opinion making and opinion formation in a democracy. Okay? Paul can give us all the facts and all the analysis, and boy, it's critical to this process. But we've got to get back to something where at some point we get people to care about the future of the country, the role of debt in that future, how we're treating our elderly, how we treat our kids, as Gene points out. And I think that it's the real issue here, and that it's all feeds into that, is it's not Medicare per se, it's this whole thing. And it's not in a very good place. So I'll close with that and leave it to Joe.
Thank you, Keith. I admire your appreciation of trust funds. I just want to clarify that the example, the one shining example, and it truly is the one shining example, referred to Social Security. And why is that? It's because retirees understand when their Social Security payments might be cut, because that's real money to them. But when we talk about Medicare, we're not really talking about cutting things that people fully understand. By and large, the federal government's approach to problems that may or may not be revealed by the trustees report have been to put it off a little bit, make adjustments in payments to providers. The political argument, of course, is, oh, we're not affecting your benefits. No, certainly we wouldn't do that. So basically what we've seen, instead of this wonderful example from Social Security, which I believe only happened once, what we've seen in the Medicare world has been modest changes, temporary putting it off, as opposed to fundamental structural reform. So I think that's something we could debate about.
Actually, can I respond to that, Joe?
Yeah, go ahead.
So Joe's a great friend. We have these debates many times. I would say that's harder to do, much harder to do in the Medicare area than it is to do in the Social Security area. And so that, in fact, what happened through the 80s and the 90s was exactly what Joe described. Many changes, incremental as they may be. And the reason is simply, as Maya pointed out, healthcare is a really dynamic technological area and in many other ways. So keeping the pressure on all those things is a good thing to do.
So if I jump in, maybe comment on this, and one other thing that Maya said, I'm offering two amendments. So one of them is on your trust fund analysis. Basically, this is more political science than is economics.
Yes.
The political science is if you have something where you're basically matching spending and revenues, and you suddenly go out of balance, and it has to be paid for at the trust fund, then you force people to come to grips with it. And in Social Security, that would work if you didn't have things like demographic shifts, like declines in the birth rate. So if you basically just all of a sudden the spending's going up a little too high, because if you look at the trust fund balance, say it's Social Security, but the same thing's happening in Medicare, it's only a piece of it in Medicare, is you hit this end point where all of a sudden you're paying out 30% more than you did, say it was 2030, you're paying out 30% more than you're getting revenues, in the trust fund goes out of balance. The old trust fund notion was simply, if you go out of balance slightly, you just have to go back into balance slightly. The other thing about it, of course, which I thought Joe was going to mention, is in the healthcare trust funds, we have a huge amount of it come out through general revenues. So to say that Part B trust fund is in balance is tautological. I'm going to define as balance because general revenues are going to cover it.
That is true. That is true.
So, but the other point I want to get to was something Maya said about, well, I hear this all the time about we don't know what to do in healthcare, and I agree in the sense the following. It's like trying to decide what healthcare should look like 10 years from now. given its size, is like trying to decide what the economy of France should look like 10 years from now. I think they're roughly of corresponding
Same
size.
size.
There's so much going on. That's not the issue. The issue is what's the process? What's the political process we set up to deal with that? And I'll do this by way of analogy. We know what not to do. And so suppose I'm debating with my wife about what our kids should do. And I think the kid should be playing the piano, and she thinks, no, the kid should be studying. That's a tough decision, right? Maybe we don't know what to do. The kid's playing in traffic. Do we know what to do? Or do we not know what to do? We know what not to do. You can't let the kid play in traffic. And I've argued in a lot of places, the fundamental original sin of healthcare, and it goes beyond government, it goes to the private sector, is you cannot set up a system where patients and providers bargain with each other or whatever everybody else will pay. Creates an infinite demand, creates an infinite supply that you cannot do. And so the result is somebody has to be able to say, no, it can be government to price controls. It can be like in Medicare Advantage where you sort of semi-voucherize the system, which you force then the insurance companies are the providers like a Kaiser Permanente to make that decision, or you could put it on the individual, which is tough because then the poor can't get things. And that's what you have to do. And the fight is going to be what's the right mix of those things about who's to say no, but you can't let the kid play in the street. And so in that sense, we do know what to do. And in that sense, it's actually simple. It's not simple politically, but it's simple economically to define it.
Well, I'd like to respond in a bit. First of all, I think the problem that we're confronted with is people have a very clear idea about what it is they don't like in health policy, right? I mean, they don't like bureaucracy. They don't like paperwork. They don't like high deductibles. They don't like high premiums. There's a lot of things they simply don't like. But if you try to get them to really be clear about what it is they actually want, well, that's different. That's a little bit more difficult. I think part of the problem that we're having in health policy, and this applies to Medicare and the general healthcare debate, is that we're actually not having a healthcare debate. We're not really debating. You know, if you go to all of these conferences, seminars, working groups, and all that sort of thing, people, you know, nobody's saying, okay, we ought to restrict access to health care. No, we ought to have access to health care. We ought to control costs. We ought to improve the quality. So we're not really actually debating those things. We're actually not in a health policy debate, and I guess I can claim the professional monopoly here. We're having a political science debate. The issue is actually who is going to make the key decisions in the system. Ultimately, at the end of the day, that seems to be the thing that is so bitter about all of this. There are a number of our colleagues, we all know them very well, who very, very strongly believe that the government should exercise a monopoly over the healthcare system. They call it a single-payer system. It is internally consistent. It is internally logic. There's an internal logic to it. Free care for all. It will be financed by taxes, and the government will ultimately control spending through a global budget. Others believe in a free market. When you say, what do you mean by a free market? Well, then it starts to get messy because people have different ideas about what a free market is in healthcare. And frankly, the United States has not had a free market in healthcare since the 1930s, when doctors were going door to door, collecting cash payments and distributing free care to poor families in the neighborhood. That was the last time we had a, quote, pure free market in healthcare. Our situation here now is we have a very, very large set of public programs, Medicare being the largest, and we have a private sector that is so highly regulated that now health insurance is virtually a public utility. Our problem is that we haven't really been able to carefully calibrate or we haven't really clearly drawn any clear lines where people are actually in agreement. I think this debate is going to be more intense, regardless of what happens on Capitol Hill this week or next week. I think we're in for a debate on healthcare for the rest of our lives, because this is a $3.2 trillion sector of the economy, which is, as you point out, immensely complex. And it's not clear to everybody what works best. There are certain areas clearly in healthcare where the public sector has a primary and a valuable and superior role. And there are other areas where the public sector actually does a very poor job. And frankly, I think delivering health care to poor people and Medicaid is one of them.
Maya?
Yeah, I'll jump in on both of those debates, because first off, who doesn't love a good debate about trust funds? And I think that's a great one. And I think the trust funds have been a mixed bag overall. So on the negative side, what they've done is they have created more of an entitlement feeling, not in terms of it's an entitlement program, which is more technical, but a feeling of being entitled to the benefits because you believe that you paid into the program, regardless of the fact that people, and Gene's done such great work on this, are getting, in general, much more out of the program than they paid into it. The second problem with the trust funds is that they're not an effective mechanism for actually saving. When we built up trust funds, if what you're able to do is save because you know a big demographic cohort is coming along, you can save in advance, that's an excellent tool. But they haven't worked that way at all, of course, because by necessity they're invested in government bonds. That makes sense. They're a safe investment. That's also how we finance deficits. It masks the overall deficit. I mean, a third effect of trust funds, and boy, do I duke this out with my father, who is usually protesting on any time I talk about entitlement reform because he wants everything he paid in because he deserves it. But the point that's often missed is that when we were using money that went into trust funds to finance the rest of government, it meant that those generations paid lower taxes for defense or the environment or whatever other things there were. And so when you talk about that money being repaid, being owed by you guys, the young people in the audience, it is really a sort of double benefit to an older generation that both put money into the program to ensure their benefits, but then used it to subsidize the rest of government and not pay for it. Those are some of the problems with trust funds. One of the good things about trust funds, I think, is that they do create a warning sign or potentially an action-forcing moment. And the big problem with government right now is they don't do anything until the very last minute. I mean, we are right now using extraordinary measures to get around the fact that we haven't lifted the debt ceiling. That's preposterous. We are doing last-minute budgeting all the time. We don't just miss the deadlines for this. We miss the deadline for everything. Everything. And part of it is a problem that people, these two parties that are so pitted against each other, think that they will not look like they negotiated hard enough if they come up with agreement before the last second. So maybe the challenge is how to figure out something that creates action-forcing moments that doesn't in the same way create a inflexibility in the budget that we currently have. Joe, I know you want to get to questions. I just want to talk quickly about the overall healthcare debate and the issues that have not been addressed. But there's so many just fundamental core questions and trade-offs in health insurance, starting with what is the role of insurance? The role of insurance is to pool risks. It's also, and that's the obvious one, nobody should go bankrupt because of healthcare costs. But it's also, and there's less agreement on this, it creates subsidies. And so who should subsidize who? Should rich subsidize poor? Should young subsidize old? Should healthy subsidize the sick? And those are all questions that just aren't discussed head on. And that's part of what's going on in this debate right now, is the tension about who should be subsidizing who. Another role of insurance, or another role that insurance plays that I'm not sure it should, is that it does a lot to cause forced savings for big moments. When you have a baby, that's an expensive outlay. I know, because my insurance company told me my daughter wasn't covered because I didn't have a child. And I was like, but I just had the child. We had a long fight with the insurance company about whether there was a baby who was insured. It's very expensive if it's not, it turns out. So we had to work through that. But those are kinds of things where there are big outlays that are somewhat predictable. My kids are going to get braces soon. There is also a role for saving in advance of big healthcare outlays, which is different than insurance. We haven't even come to terms with the fundamental role of insurance. We still won't agree, but at least we should have that discussion. That discussion is nowhere to be found in this current health care debate. And then questions about who should be choosing what things people should have to have. So I just go back to kind of the public policy first principles. What problems are you trying to solve? What are the different structures that you could use to solve them? Disagreement's legitimate, but let's lay them out transparently. And then the pros and cons of the different approaches. And yes, we'll be having that debate forever.
These are great comments. We have time for about 2 questions. Quickly, move quickly, speak quickly. He doesn't. I'll repeat your question. Just go on.
The need for having a debate about this long-term overall spending, and Keith, I'm glad you brought up the point of capital spending.
What's the question?
Nothing in this report is going to, I hate to sound a little skeptical, but if
Okay, so the questions are, what happens to IPAB and what's going to get Congress to do anything? Right?
I can tell you that I know there are bills on the Hill that have been proposed to repeal IPAB. And there was a special mechanism in the legislation that depends on resolutions being introduced as of February this year. But it does cost money against the CBO baseline, so I don't believe it's in any of the bills on the Hill that are moving now. Not as part of the ACA measure. I don't know about how I'm going to get Congress to do something. Maybe Bob.
Okay, question, quickly.
Hi.
Next question, over here,
Paul Hellman
right here.
with Hellman Simpson Partners.
You.
I want to get in the weeds with Paul for a minute. Does it work? Oh, it works. Okay. Paul Heldman with Heldman Simpson Partners. There's a couple things that jumped out. There's again a sharp jump in Medicare Part D per capita growth for 2018, and a sharp jump in 2019 Medicare per capita spending. And I'm wondering what are the causes of those, and what should we read into that about future trends? And also, if you could just explain why the manufacturer rebates went up. Is that just you just suddenly noticed new data, or are we seeing some new trend, and what's causing that?
Well, there's been a lot of shifts of what's happening in the Part D market as I went through in some respect. And in particular, there have been more rebates that have been earned in the program, and that's continuing to come through. You could actually look at the projections of the share of rebates that are coming through, and they've changed dramatically over a very short period of time, and we're projecting that that will continue for at least some period in the future. In terms of year-to-year changes, we have moved to a more micro model in terms of building up those trends, and so we might be more explicitly projecting specific drugs going off patent or potentially coming on market.
Right. Thank you very much. Unfortunately, we've run out of time. Please join me in thanking the panel for a terrific discussion.